Hello, class. Okay. This is going to be for your next exam, exam 3, which is in about 2 weeks. Okay. So the chapters will be chapter 19, 20, 19, 20, 21, 22, and 23. Chapter 24 is going to be on your final. The final is going to be cumulative. Okay, so keep that in mind. Okay, so I am going to share the screen. So that way you will be able to follow the book, the notes, and do this. So the purpose of this recording is for you to prepare yourself for lecture for next week. So you read the book, you read the pointers and everything else. You will have a blueprint in front of you. You follow, you go by the blueprint, you study by the blueprint. Next week we're in class. We'll do the same thing. So if you have any questions, you'll have it there, okay? And we'll do a little bit more, you know, kind of getting your head prepared for this third quiz exam number 3. Okay, so chapter 19. Okay, so we have chapter 19 here, and just want to make sure. Should. Great. Okay. And so we have chapter 19. Chapter 19 is going to be based on addiction. Okay. Chapter 19. Okay, there we go. And again, key terms to look at: stimulants, tapering, tolerance, withdrawal symptoms. So you have that. So you want to make sure that you're looking, that you're reading the introduction. This is based on addiction. Read the introduction, get to understand like the meaning of addiction, okay? And it's gonna help you. So as you're going along in the chapter, you already have that kind of piece. And this is not just for this chapter, this is for all of your chapters. So addiction, being addicted to something, substance use disorder, and related disorders are national health problems. And you'll see that a lot more in adolescents and teens. So during your assessment as a nurse, think of you coming in, you're the nurse doing the intake, you will see a lot of more adolescents coming in between the ages of 12 to 17 years old who have alcohol use disorder. And they do, you know, and you have the binge drinking, and you're going to have, because of the parties and everything else and those shots that they do. I know before I said a lot of times students, I said to my other students, I think the day students, about how teenage girls usually take tampons and dip it in alcohol to get that really sudden, quick high. And that can cause a lot of alcohol toxicity. So you want to make sure that you keep that in mind about who you're going to be looking at, mostly when you're doing your assessment intake. So there's types of substance abuse. There's different types. One we call something called polypharmacy. When it comes to the elderly, they use a lot of medication because they have medication that cure this and in this illness and this illness. In this case, when it comes to addiction, abuse of more than one substance is termed polysubstance abuse. So here's a wonderful picture of, someone for DUI to get it out, and the cop is checking them. So when it comes to drugs and alcohol, that can lead to a lot of legal problem. So categories of drugs is going to include, and when we're talking about addiction and substance abuse, it just is not alcohol, but it's going to include alcohol, sedatives, hypnotics, the anxiolytics, those drugs we talked about, all those drugs we talked about in the other chapters, the stimulus, because, and they're using it to treat one illness, which is mental illness. But they can become very addicted to it. This is why the physician has to always go in and, either readjust the meds or maybe not even write a prescription for them anymore if they seem like they have a addictive behavior to that particular medication. You have cannabis, you have opioids, you have hallucinogens, and also inhalants. So when people start taking these drugs and medication, of course, they become intoxicated if it's too much or too overly. And intoxication is the use of a substance that results in a maladaptive behavior. And then then we have another term called withdrawal syndrome, in which a person may want to go in and say, by the way, I want to finish, I don't want to do this anymore. Or they are going into a treatment center and they're trying to not take the drugs or the substance anymore. They can go into a withdrawal syndrome, which refers to the negative psychological and physical reactions that occur when use of a substance ceases or dramatically decreases. And you see that a lot of times when the patient goes into rehab, when they try to do this whole detoxification. And it's like taking, candy, I hate to use the phrase, candy away from a baby, where the baby just like screams and like just goes into whatever, frantic they want to go into. But because they're not having the candy. So think of the body not having this urge or whatever they were getting to kind of make them feel that euphoria or that high. So now the body is reacting. So detoxification is the process of safely withdrawing from the substance. This is a safer way. And this is the best way you want to tell your patient, if you are going to want to stop the medication, you have to go through a whole detoxification, because it's going to be a safer way, because they know how to do it. You have professionals around you. The treatment of other substance-induced disorders such as psychosis and mood disorders is going to, we're going to talk about that later on in the other chapters. But they will have, during the detoxification, they will have some symptoms of withdrawal symptoms, but at least someone is there during the whole detoxification. Substance abuse can be defined as using a drug in a way that is inconsistent with medical and social norms, and despite negative consequences. Substance abuse denotes problems in social, vocational, or legal areas in a person's life, while substance dependence, it also includes problems associated with addiction. But people could they could tolerate it, withdrawal and unsuccessful attempts to stop using the substance. Okay, so that's our piece on the introduction to this that you need to know. So the onset and clinical course. Okay, the onset and clinical course. You have some people who you have keywords here during, for the onset. Research on substance has focused on alcohol because it's legal and more widely used. But you do have the other ones where you have the other drugs and so forth that we talked about. And you do have some other related disorders, it's like gambling disorders, and they even have caffeine and tobacco and nicotine that can be addictive. So you have different other related disorders that go with this. Looking at the etiology of the addictive, but the biological piece, they said that children of alcoholic parents are at higher risk for developing alcoholism and also drug dependency. When we're looking at the neurochemical influence on substance use, patterns have been studied patterns have been studied primarily, and they did it on, on animal research, in which they see that the ingestion of like a mood altering drug or substance, it affects the dopamine pathways in the limbic system. And when that happens, it produces a pleasant feeling or a high that is reinforcing a positive experience for that particular patient. Okay, so it's when you're looking at the biological factors. And then you have other factors. So when the cultural considerations, sometimes you have certain cultures who just a sip of alcohol can make them drunk really, really fast, or maybe they may have some type of flushing of the face. And you usually see this highest among people of the Asian ancestry. You see that there. So there are some cultural considerations. Types of substance and treatment. So the types of substance and treatment, the classes of mood altering substances have more similarities and differences in terms of intended effect. Intoxication effects and withdrawal symptoms. So you see that. So treatment approaches after detoxification, however, are quite similar. So in this section, you're going to look at the different drugs, what happens when during alcohol, or intoxication, they're overdose. So you just look at, you'll be seeing that. And again, I'm just going to pinpoint a lot of things in each chapter for you right now. I'm not going through the whole chapter, but just pinpointing some things out to you to class. Okay, so alcohol. So you're looking at the alcohol, intoxication, and also the overdose. So when earlier I said when it comes to intoxication, the person is taking over the amount that their body can actually deal with, or and alcohol is a central nervous system depressant because it depresses the central nervous system, and this is absorbed rapidly into the bloodstream. So imagine too much of it, so the person becomes really intoxicated. You may see them with a slurred speech, they can't walk, lack of coordination. And these are some of the physiological effects of a long-term alcohol use that can happen to a person. And one of them is, cirrhosis of the liver. You've probably heard of that. In the enlarge of the abdominal area, which you'll see that's considered to be ascites. So when the person wants to go get help, or withdraw, to get all of this out of them, detoxification and withdrawal comes into play. Symptoms of withdrawal usually begin 4 to 12 hours after cessation or marked reduction of alcohol intake. So symptoms are going to include coarse hand tremors, sweating, elevated pulse, blood pressure, insomnia, anxiety, and nausea and vomiting. And this can be, alcohol can be life-threatening. Also, and detoxification needs to be accomplished, like I said, under medical supervision. So you always want to make that clear. If someone says they want to withdraw really quick, you want to make sure that they are doing this under medical supervision. So safe withdrawal is usually accomplished with the administration of some type of benzodiazepine, and one of the benzodiazepines of choice is Ativan. Another one is Librium. You have Valium to help suppress these withdrawal symptoms. Okay. And this is a chart, box 19.2, Addiction Research Foundation, Clinical Institute Withdrawal Assessment for Alcohol. If you have a patient coming in and you're doing their assessment, this is probably one of the assessments that they'll do. They will ask about nausea and vomiting, tremor, any type of paroxysmal sweats, anxiety, agitation, tactile disturbances, alcohol disturbances, visual disturbances. So all of these you will see like if the patient is going through, you'll see that in regards to withdrawal. So that was alcohol. Now, sedative and hypnotics and anxiolytics, of course, so intoxication and overdose. So this is a class of drugs, includes all central nervous system depressants. You'll see the barbiturates, the anxiolytics, particularly the benzodiazepines. Benzodiazepines and barbiturates are most frequently abused drugs within this category. And so the intoxication symptoms is going to include the slurred speech, the lack of coordination, the unsteady gait, the stupor, even the patient going into a coma. Benzodiazepines, even taken by itself orally, can be very fatal. And if the patient, especially if the patient is lethargic and already confused. Treatment includes bringing it out, taking it out, the lavage treatments, the activated charcoal. So you have certain treatments when the patient does go into, if they overdose. I always tell students to read the clinical vignette because that's a case study, and usually sometimes when you're reading case studies, it stays in your mind. So always make sure you try to read each clinical vignette. Withdrawal and detoxification for this category, you're looking at, it tells you the onset of withdrawal symptoms depends on the half-life of the drugs, how long the drugs is going to stay in the system. So you have medications such as lorazepam with actions that typically last about 10 hours, produce withdrawal symptoms in 6 to 8 hours. Longer acting medications such as diazepam may not produce withdrawal symptoms for 1 week. So you want to make sure you read this. It's going to explain a little bit more to you. But detoxification from sedatives, hypnotics, and anxiolytics is often medically managed by tapering. You want to taper the drug. And the amount of drug the client receives over a period of days and a period of weeks, depending on the drug and the amount the client have been using. So tapering is administering decreased doses of the medication. And that's essential with barbiturates to prevent any type of coma or death that occurs if the drug is stopped abruptly. Okay, then you have those stimulants. Okay, remember those stimulants, the amphetamines, so the stimulants are drugs that stimulate or excite the central nervous system, and they have a limited clinical use. With here it tells you, with the exception of stimulants used to treat the ADHD, remember the attention deficit disorders, what we saw in chapter 22. A high potential, the person can have a high potential for abuse. This is why you want to make sure that you're monitoring teens when they're taking these particular medication, because amphetamines are uppers. Back then people were using them to lose weight. People became addicted to them because it helped them stay awake. Cocaine back then, a stimulant, is an illegal drug with virtually no clinical use in medicine at all. That's another highly addictive and popular recreational drug because of the intense and immediate feeling of that euphoria that it produces. Back then, and during the time when cocaine first came out, that was very, very expensive drugs. A lot of people who with money usually bought that. But then when it started going into the streets, they changed the cocaine. It went over to become crack cocaine, which made it a less expensive drug to buy. And people to this day are still addicted to that. Methamphetamine is particularly dangerous. It is a highly addictive drug, and it does cause psychotic behaviors. It can go to lead to brain damage. Related to its uses, frequent primarily as a result of substance use to make the book tells you a liquid a fertilizer. So people are using these drugs, and these drugs are used to do other things like like here it says a liquid fertilizer. So when it comes to those stimulants, intoxication and overdose, from stimulants that develop rapidly. Again, you get that high, that euphoric feeling, the hyperactivity, chattiness, talkativeness, anxiety, the whole mind of I can do this, the grandiosity, the hallucinations. So you have all of that. And overdose of stimulants can result into a seizure, it can result into a coma and lead to death. Treatments with thorazine, you know, and also thorazine, which is an antipsychotic, that can help control those hallucinations. And also what it does, it lowers blood pressure, and it can also help relieve any type of nausea. So that's what you want to look at when it comes to the stimulants. Cannabis, another drug when it comes to intoxication. So cannabis is world known. Marijuana, that's another word for cannabis. They have different names for each of these drugs. So cannabis sativa is a hemp plant that is widely cultivated for its fiber used to make rope and cloth, and for oil from its seeds. And so it has become widely known for its psychoactive resin. And this resin contains more than 60 substances called cannabinoids, of which a chemical called tetrahydrocannabinol is thought to be responsible for most of the psychoactive effects. So marijuana refers to the upper leaves and the flowering tops and the stems of the plant. Hashish is a dried resinous exudate from the leaves of the female plant. And cannabis is often smoked in cigarettes or AKA joints, and it can also be eaten, those edibles that you see out there. So intoxication and overdose. So intoxication and overdose, cannabis begins to act less than 1 minute after inhalation. The peak effect usually occurs 20 to 30 minutes and lasts at least 2 to 3 hours. People who do use it, they get that high feeling. So that with alcohol or lower inhibition, relaxation, or euphoria, and also increased appetite. When it comes to withdrawal and detoxification, some people have reported withdrawal symptoms of muscle aches, sweating, anxiety, and tremors. No clinically significant withdrawal syndrome is identified. The opioids are other popular drugs because they desensitize the user to both physiological and psychological pain and induce a sense of euphoria and being well. So that opioid abuse is something you see every single day. I always say school moms, soccer moms, they pop these drugs, they get them from the physician, they probably had an injury, get them, and then they become addicted to it. So opioid compounds include both potent prescription analgesics such as morphine, Demerol, codeine, hydromorphone. All these things you hear are drugs that are prescribed by the physician. And when it comes to intoxication and overdose, when Narcan, you always want to make sure you have administration of Narcan on hand, and which is an opioid antagonist. And this is the treatment of choice because it reverses all signs of opioid toxicity. Opioid withdrawal develops when drug intake ceases or decrease markedly, or it can be precipitated by the administration of an opioid antagonist. And initial symptoms are anxiety, restlessness, aching back and legs, and so forth that you'll see when it comes to that. Those hallucinogens are substances that distort the user's perception of reality and produce symptoms similar to psychosis, including hallucinations, usually visual and usually visual and depersonalization. So when you see those hallucinogens, the patient, the hallucinogens is what it says, hallucinogens, hallucinating, and they cause, and the increased pulse, the blood pressure goes up, temperature goes up, the dilated pupils, the hyper reflexia, and some example, one example is mescaline. They even have designer drugs such as like called ecstasy, and PCP also is one of those designer drugs. And so a hallucinogen, heart rate going up, and all of a sudden that little mouse becomes something more grand, which is a lion that they actually see, and because their reality has been distorted. Intoxication, physiological symptoms are going to include the sweating, the tachycardia, and the palpitations, and hallucinogen intoxication is marked by several maladaptive behaviors, and psychological changes. The patient can become depressed, paranoid, have those ideals of reference. So they have all of that, and they could even get to the point where they feel like they can fly. They can be, on a balcony or something, and they get this ideal that they can just fly, and because their mind is so the reality in their mind is so distorted. And withdrawal detoxification. So no withdrawal syndrome has been identified for hallucinogens. Some people have reported craving for the drug afterwards. Hallucinogens can produce flashbacks, which are transient reoccurrences of perceptual disturbances like those experienced with hallucinogens, the use of it. Inhalants. When you think of that, just think of anything like gasoline, glue, paint thinners, anything around the home, the household that a teen can actually get, or a child can get. Stupor and coma can actually occur, blur vision, in regards to intoxication and also overdose. Okay. So treatment and prognosis. So there are different treatments and prognosis that you'll see. You can read through this. I'm just going to go down. They have the different treatment settings. When it comes to this exam, the nursing care plan, alcohol treatment program, and the nursing, the nursing diagnosis. Now that you understand and know this, different things in regards to the, the addiction, your thing is going to be what you're going to do as a nurse, your assessment data, and your expected outcomes on when you're communicating with the patient. So it's going to be a lot of communication. It's going to be communication questions. We're going to go over that next week so you can kind of get used to those communication questions. Okay. You're going to need to look at expected outcomes and what to do, the immediate stabilization, community, and what you're going to do with what you want your patient to do, and understanding that. Then you're going to have your nursing interventions. You don't have to memorize nursing interventions, but but knowing those outcomes is going to help you when it comes to looking at the nursing intervention. You don't have to know this drug chart, okay? And we already talked about certain things, the symptoms that's going to cause a withdrawal, so you don't have to know this drug chart, okay? But the nursing intervention and understanding that. Okay, here's another one. This talks about dual diagnosis when you have a patient who is having a mental illness and also they have or on a substance, or using some type of substance. Okay, just really the nursing outcomes and interventions that you want to make sure that you that you look at. So whatever I just highlighted, the area, I think it was the other chart, you want to look at that. This one talks about the dual diagnosis. And you can just do an overview of that. Okay. And okay. Also, we always want to make sure we always do assessments, have some RN. So understanding, so this will help you too. Looking at the assessment piece at the end of each chapter. So you have the patient's history, and this is again, this is the chapter for addiction. You're looking at the general appearance, the motor behavior, mood and effect, thought process and content, and so forth. Self-concept comes out of this because when it comes to a patient with addiction, the clients generally have low self-esteem, and they usually cover it up. They may just especially you have those, you have people who are like in a high power or position or something, and they will cover it up and they have this grandiose behavior. And they do this to cover everything up, and they usually cover it up by drinking alcohol or some type of addictive behavior. I know some people who would drink alcohol in order to be able to express themselves around people or, and talk to people. So you want to make sure you understand what the self-concept is, okay? When it comes to the intervention, family. So these are questions that's going to be popping up on you. Family. So providing health teaching for the client and the family, educating them. And, because a lot of time they can revert back to their old behavior, saying, I'm okay, I'm fine, I can go hang out with my friends, my buddies, I'm not going to do anything. But a lot of times they can relapse and go back into their old behavior. So you want to make sure you're looking at that in regards to the family. Even substance abuse in the healthcare professionals working with someone who may be taking a pain pill or doing something or not giving the patient their medication. So look at substance abuse in the health professional and what you have to do in regards to reporting your coworker. And self-awareness issues, the nurse must examine his or her own beliefs and attitudes when it comes to substance abuse, especially understanding yourself in regards to it and being able to talk to your colleagues about it, if they don't understand it, if you have a patient that comes in and they don't have too much knowledge about it themselves, okay? All right, so chapter 19. Oh, that was chapter 19, so we're into eating disorders, chapter 20. Okay, so again, introduce yourself to it. Always introduce yourself to it. And to get to understand, always read the introduction. Read the introduction, take your time, read the introduction. Here's the overview of eating disorders. Read that to get to understand what an eating disorder is. Because the really ones are going to be bulimia and anorexia. So you want to just go back into the history and see where it kind of stemmed from. So let's look at the first one. The first one, categories of eating disorders. You have anorexia nervosa. And with anorexia nervosa is a life-threatening, eating disorder, and is characterized by the client's restriction of their nutritional intake necessary to maintain, their body weight. And in their mind, they're fearing that they are gaining weight, and the fat, the body disturbances. So in their mind, they just don't feel like they can be very small, but in their mind, when they're looking in the mirror, they see something else. So and patients with anorexia have a body weight that is less than the minimal expected weight considering age, height, and overall physical health. In addition, the clients have a preoccupation with food and food-related activities and can have a variety of physical manifestation that you see here in box 20.1. So look at, make sure you understand, look at these physical problems of the anorexia nervosa so you can know the signs and symptoms. Their behaviors, looking at their behaviors and and what they do. So you want to see that the binge eating, the purging, and their sense of control. The whole thing is having that control, their sense of control, by making sure that they keep the weight down, they continue to do these things, and they have to have that sense of control. Excessive exercise, you'll see them doing that. It may occupy several times or hours a day. You see them running. One of my neighbors, like an old neighbor, I don't see her anymore. I haven't seen her in a while. So hopefully she's okay. But she was very, very thin, and I knew she was anorexic. She was thin to the point you could see her rib cage, you could see the bone. She looked like a running skeleton. And every day you'll see how they're running. Bulimia nervosa, often it's called bulimia, is an eating disorder and is characterized by recurrent episodes of binge eating followed by inappropriate compensatory behaviors to avoid weight gain. So they eat, they purge, they actually eat excessively, and they also do excessive exercise, but they really eat like a lot of food. The client often engages in binge eating secretly. Between binges, the client may eat low-calorie foods, or they may fast. And binging or purging episodes are often precipitated by strong emotions and followed by guilt, remorse, shame, and so forth. So you want to look at both of them. You want to see the difference between bulimia. You want to look at the difference between anorexia nervosa. Also they're going to have related disorders, binge eating disorders, night eating syndrome. These are some of the related disorders. Pica, rumination, where I had a patient who did a lot of rumination. They would pocket the food in their mouth and swallow it and just kind of repeat a regurgitation. I had a patient that, but that's because she had a lot of trauma that happened prior to that caused her to do the regurgitation, because in her mind, she wasn't going to get any more food. And so here, table 20.1 shows you the disorders: anorexia nervosa and bulimia nervosa. Anorexia nervosa, obesity, dieting at an early age, issues of developing autonomy and having control over self. So again, when you're looking at this, anorexia nervosa is going to be really about having control over self, environment, developing a unique identity. So it's going to be, keep that in mind about the control. Family lacks emotional support. And when it comes to bulimia, obesity, early dieting, possible serotonin and norepinephrine disturbances. I remember we talked about the serotonin, the sleeping, and we talked about the serotonin last week. Self-perceptions of being overweight, fat, unattractive, undesirable, dissatisfaction with their body image. Okay. So that's table 20.1. Do you have some biological factors? So the developmental factors, you got two, when it comes to, it's two essential tasks of adolescents are struggling to develop autonomy. They're knowing themselves and establishment of unique identity. So autonomy or exerting control over oneself in an environment may be difficult and families that are very protective. They're not letting the person have their sense of autonomy, being themselves, making their choices on what they want to be or what they have to look like. So you see that. And so this is when it comes to the body image disturbances occurs when there is an extreme discrepancy between one's body image and the perception of how everybody else perceives them and want them to be. Okay. And okay. So anorexia nervosa, let's see what we have here. Medical complications when it comes to eating disorders. So you want to look at this, the body system, the symptoms, metabolic disorders are going to be the main ones, especially when it comes related to weight loss. And then also related to purging, what happens when it comes to the metabolic system, okay? Psychopharmacs, medications such as Zyprexa has been used with success because of the antipsychotic effect when it comes to the body image, the distorted body image that they have in their mind, and also associated weight gain. Psychotherapy is therapy that focuses on the client's issues and circumstances, having the coping skills, building up their self-esteem, so you want to make sure you look at the psychotherapy because it's going to help you a lot. And again, when it comes to the interventions and communicating with your patient. Okay, so let's go down and look at the nursing interventions and the care plan. So this is something on bulimia. Okay, so you want to make sure you understand this. Again, these exams are based on communication and nursing assessments. It's going to be a lot of that. What you're going to be expecting out of your patient, the expected outcomes. Okay, so that one's on bulimia. And you don't have to read the whole thing. So go down to the assessment. When you go down to the assessment piece, that's going to help you a lot. So you have, let's go back. Assessment starts here with the history and everything else, right? So you have that. You're going to be doing your patient's assessment. What are you going to be looking for? Okay. This is just one of the care plans. Go and look at the expected outcomes, what you're going to expect from your patient. Okay. And then part of the assessment, reading the different contents in it. What are you going to be looking at? Thought process, that part of the contents, and judgment and insight, self-concept. Make sure you read that, okay? And go over those pieces. Some nursing care plans might come out so you can know what you're going to be looking for in regards to data analysis, imbalanced nutrition, less than more than body requirements, disturbed body images, this concept mastery alert for clients with anorexia. The risk of dehydration supersedes the risk of imbalanced nutrition in the short term. So often giving them parental nutrition may help, may help them. Then we're going to look at some interventions. One of them is establishing nutritional eating patterns. This is very important. And one, like I said, the TPN or total parental nutrition will be given to your patient. Other nursing interventions, eating disorders. You're looking at what to do, like offering liquid protein if the patient cannot complete a meal, helping the client identify emotional and develop non-food related coping strategies, self-monitoring. Okay, so these are some of the things you want to make sure that you're reading. Okay, just pinpoint your reading, pinpoint your reading in certain areas. Body image, okay, it's another one. Just pinpoint your reading in these certain areas. Client and family education, providing emotional support. letting them know that you love it and you're giving them that attention, the family is, and that they're having that attention, okay? So just pinpoint certain areas because it's going to be a lot of communication and patient teaching on this test. So you want to pinpoint those areas and what you have to do with your patient, okay? This chapter here, chapter 21. So chapter 21, somatic symptoms illness. So this chapter here, it's based on really the mind of a person who they may be sick or they can make themselves sick, but they have these illnesses where the doctor doesn't see that they are really sick. So looking at the introduction, so because the mind can cause the body either to create physical symptoms or to worsen physical symptoms. Any real symptoms can begin because the mind is that deep. So basically real symptoms can begin, real symptoms can continue, or real symptoms can be worsened as a result of emotional factors. For example, diabetes, hypertension, inflammation of the stomach or the colon, colitis, are all which medical illnesses can be influenced by stress and also emotion. So when a person is under a lot of stress or is not coping well with stress, symptoms of these medical illness, they can worsen. In addition, stress can cause physical symptoms unrelated to a diagnosis or medical illness. So reading this and, introduction, I would read this chapter, kind of get to understand what somatic illnesses is because, just to understand it, but everything checks out normal. The patient goes to the doctor and they have any symptoms, but everything is checking out normal. Sigmund Freud, he talked about it. I observed that people with some type of hysteria improved with when they were hypnotized, and they relieved them from these symptoms. So overview of somatic symptom illnesses. So somatization is defined as the transference of mental experiences and states into bodily symptoms. So somatic symptom illness can be characterized as the presence of physical symptoms that suggest a medical condition without some type of base or account for them or blood work, medical reason. So 3 central features of somatic symptom illness are as follows. Physical complaints suggest major medical illnesses, but have no demonstrable organic basis. So that 3 right here. Okay. Psychological, so that's physical complaints. So physical complaints suggest major medical illness. Psychological factors and conflicts seem important in initiating, exacerbating, and maintaining the symptoms. They just continue to do it and say, I feel it, I know it's there. Symptoms or magnified health concerns are not under the client's conscious control. So clients are convinced they harbor serious physical problems despite negative results during a diagnostic test. And that's exactly what you're gonna see. Somatic symptom disorders, they can include somatic symptoms, they have, well, nurses must remember, as a nurse, you must remember that these clients really experience these symptoms. They describe and cannot voluntarily, they cannot control them. So somatic symptoms, you have the different disorders. You have somatic symptom disorders. So know the difference between, you want to know what somatic symptom disorder is, okay? Conversion disorder, pain disorder here, and illness anxiety disorder, okay? Formerly like a hypochondriac, okay? So know the difference between, read these and know the difference between those when you're doing the overview. Okay, so let's go down. And they have related disorders such as fabricated induced illness, malingering, fictitious disorder. So they have even the Munchkin syndrome, proxy syndrome. We'll discuss that next week, those separate disorders. Conversion disorder, okay? Now this is where everything comes in, your potatoes, your everything that you need to know. Going back into the nursing care plan. Understand, looking at the assessment data. This one, secondary gain, related to physical symptom or disability. Verbalizing knowledge of the illness, including the concept of secondary gain. Okay, and secondary gain, it's gonna come up. I think it's gonna go after that. You'll see it when it comes to secondary gain. We'll go back, go through it. Okay, so again, so some nursing, so your nursing care plan is going to come into effect. So let's look at this. So etiology, the psychosocial theories, the theorists, they believe that people with somatic illness keep the stress and anxiety or the frustration, to keep it inside. They express these internalized feelings through stress and through physical symptoms, basically, or psychological symptoms, basically to somatize it, okay? The worsening of physical symptoms helps them meet that whole psychological need for security, for attention. And this is an affection through primary and also through the secondary gain. So primary gains are the indirect internal benefits that being sick provides, okay? So that's the primary gain, I'm sick and this is, I gotta get this attention and so forth. But the secondary gains are the external and personal benefits received from others, because one is sick, such attention from the family members, the comfort measures, people calling them, are you okay? Is everything fine? Do you need any help? So the person soon learns that he or she needs to be sick to have his or her emotional needs met, okay? So that piece is important when it comes to the etiology of it. So you wanna read that. It goes a little bit more into about what somatization is and what people are gonna be seeking and psychologically on how they actually think in regards to that. Okay, so I'm just gonna go through, okay, and this is where we're gonna go into the assessments, okay, the histories. Okay, so somatization, looking at the thought process and the content. So you want to make sure you're reading that, okay, how they think, especially because this is all about real more psychological. So you want to make sure you're looking at that. And okay, and here's some interventions here. When you're looking at, I highlighted one intervention about you want to encourage them to keep a diary about situations and stress and symptoms and everything, so and reflect on those items, and every time something happens to them, what happens, what symptoms are going to be coming up, so they can kind of start to see the relation about what's going on. Then you can also teach the client more healthy daily living habits, including the diet and the rest, and the rationale for this one is optimal physical wellness is especially important with clients using physical symptoms such as their coping strategies. You want to make sure that you're doing that. And here's another one, assisting the client in expressing their emotions, teaching coping strategies. Make sure you read these because again, it's going to be part of it's going to be a lot of communication and patient teaching within this. Even dealing with the client and the family and educating educate the client in relaxation techniques, progressive relaxation, deep breathing. And then when it comes to the evaluation, somatic illnesses are chronic or reoccurrent, so changes are likely to occur slowly. So if treatment is effective, the client should make fewer visits to the physician as a result of physical complaints. They should use less medication and then basically really use more coping techniques, okay? Okay, so let's go into the next chapter, which is chapter 22. Neural developmental disorders. Okay, so we'll just go through this and pinpoint everything here. So you can begin to study and just get some things out of the study and then writing it down. And again, you can follow your blueprint. Okay, introduction. Psychiatric disorders are not diagnosed as easily in children as they are in adults. So you're going to see it's children and adolescents, it's not going to be that easily done. So again, you want to read this introduction here. I'm just going to go through this chapter and look at certain related disorders when it comes to the neurological development, tic disorders. Knowing your definitions here. So a tic is a sudden, rapid, reoccurrent, non-rhythmic, stereotype motor movement or vocalization. So tics can be suppressed, but not indefinitely. So you have some common, simple types of tics. You might hear the person clearing the throat, grunting, sniffing, snorting, or barking. And they have some definitions here. One of them is that you may see. You have coprolia is the use of social unacceptable words. Frequently, that could be very obscene. You have palilia, repeating one's own sounds or words. Echolalia, repeating the last heard sound or word or phrase. So you have those different types of tics. Tourette disorder involves multiple motor tics, one or more vocal tics, which occur many times a day for more than a year. So the complexity and severity of the tics change over time, and the person experiences almost all the possible tics described previously during his or her lifetime. Okay, so this falls under tic disorders, and so let's go back. So again, you want to read the. Let's go back. So introduction. Okay, so you have the children and adolescents experience some mental health problems, such as adults, such as mood and anxiety disorders, and are diagnosed with disorders usually using the same criteria for adults, such as like you have the eating disorder, the anorexia nervosa. But then you're looking at the neurological development, so intellectual disability. And you will see that autism spectrum falls under that. So this you want to read in regards to autism spectrum, the behaviors that's going to be common with the autism spectrum. Okay, so you want to make sure that's box 22.1. But then you're going to have those related disorders that can go along with this. And that's when you're looking at the tic disorders, okay? Those are your related disorders, Tourette disorders, okay? So now, but mostly we're gonna go and look at, you have your ADHD, you have that here, and we talked about that before, okay? And understanding ADHD, the onset and clinical course, the child can be interrupted. They like to, you want to know the different levels, the school age and what they do during the time and those signs and symptoms. So you want to look at all of that to understand, what they do there. And so it's going to be, so again, we're going to go down And here we go, the nursing care plan, the nursing diagnosis. So after understanding everything on top and just probably reading through that, now you have your nursing diagnosis, your assessment data on what you're going to be doing with the patient. And when you're caring for those particular patient, your nursing interventions, I highlighted some for you here, especially when you're giving them certain tasks to do. Okay. In the treatment and medications, you want to look at that. Catching a teeny little cold here. So giving stimulus during, so the time you give the stimulants, excuse me, that's going to be very important. So giving stimulants during the daytime hours usually are effective in the combats insomnia. Having the patient eat a good breakfast or a snack, a nutritious snack. And at bedtime, it helps the child maintain an adequate dietary intake. So you want to look at the psychopharmacological, particularly what time these medications, these stimulants should be given. Okay. Okay, going back to nursing interventions again, looking at the safety, ensuring the safety for the child with ADHD. Okay, so you always want to make sure that you provide close supervision when it comes to the child with ADHD. Providing client and family education and support, especially with the parents, sometimes they feel overwhelmed. Okay. And okay, and again, we're going to go over this in school, and then self-awareness issues. So I'm just pinpointing certain areas where you want to be reading this over this weekend, okay? So all the areas that's highlighted, just make sure you go back and read that whole area, read it, and to get the understanding of it, okay? All right. Then we have the next chapter, chapter 23, disruptive behavior disorders. Disruptive behavior disorder. So here we go. Again, the introduction, understanding, okay, disruptive behavior disorder. So I'm just going to go through the pinpoints of what you need to start to read this weekend to kind of know what to study and to go over your blueprint. So disruptive behavior disorder, and they have the related disorders that you can do an overview on. And of course, I'm going to show you the other ones. So you have intermittent explosive disorders. Make sure you're reading on this one and understanding this piece, okay? So intermittent explosive disorder, knowing what that is. Conduct disorder, okay? Read through that. And knowing that, the different ones, when it comes to conduct disorder, you have mild, okay? Moderate and severe. That you want to know the difference. When it comes to severe, you start seeing those physical fights and cruelty to animals and, weapons, burglary. So you see that when it comes to the conduct disorder. So you want to look at that and understand that. And again, your clinical vignet, it's good to read. So now we're down to looking at the nursing care plans and the interventions. Okay, this one is on the conduct disorder. Okay, and so you have the assessment data, what you're going to be looking at, what the client will do. Some of your nursing interventions, especially if they're acting out, teach the, limit their setting, limitation, time for discussion, sitting down, like really kind of time out. You do have, and they have some related problems here. So now we're going to go look at roles and relationships. Is one of your assessments that you're going to be looking at. Okay. Identifying, you know, they're destructive. They don't listen to teachers, police, anything of authority. So you want to look at the roles and relationship is when you, based on your assessment, what is the information that you're getting from them. Then you're going to come down, your interventions is going to be very important when it comes, again, to these chapters. You know, providing consistent, limited enforcement, you know, and the patient, telling the parents they have to be consistent with what they tell them to do. Like, you know, you can't change it up in the middle because then they're going to start all over again. Even having a written contract, you as a nurse, a plan, the staff must be consistent. You have to be consistent with the clients. Okay. And these are some nursing interventions for conduct disorder there. Okay, so right here, providing client and family education. You want to make sure how you're educating the patient, the family prior to discharge, and what you're going to educate them on when it comes to the community-based care when they go out. A lot of them are going to be going into group homes, halfway houses, residential communities. So you want to make sure that you understand and communicate this to the family members and to the client. So clients with conduct disorder are seen in acute care settings only when their behavior is severe, okay? And only for short periods of time to really basically stabilize them, okay? And, all right. So that's it. So the blueprint, you want to follow, again, you want to look, the chapters are chapters 19, 20, 21, 22, and 23. You're going to follow along with the blueprint that you have, and then do your reading from there. Next week, we're in class. We're gonna do your heads, tickle your brains, see where you're at. And we'll go through the slides again if needed. Probably, and we'll just really kind of get some questions in your head to kind of see where you are. Okay. All right. And you have a wonderful weekend. Make sure that you do begin to study. Okay. Yeah.